Okay, so I'm talking today about palliative care and trying to dispel some myths about palliative care to get a better definition. And Dr. Simon and others across the Parkinson's Foundation are part of a project that I'll describe later. But really talking about how palliative care can help people to live as well as possible for as long as possible. I've received support from this work from a number of sources, and I put up this slide just to let people know that this is an area where there is actually a lot of very active growth and very active research, because it hopefully will convince you by the end of the lecture is one of the ways that we can improve care today, even as we're waiting for a cure. So my goals for this talk are to really understand the goals of palliative care and hospice, to understand how palliative care and hospice can improve quality of life for people living with Parkinson's and their families, and to talk about ways that you can advocate for yourself or your loved one using a palliative care approach. And to do so, we'll kind of go through four areas. One is just going through some definitions. There's a lot of, I think, misperceptions about what palliative care is. We'll talk about what are the palliative care needs in Parkinson's disease. I'll present some evidence that palliative care can improve outcomes for people living with Parkinson's and their families. And lastly, we'll talk about strategies that you can use to access palliative care and bring a palliative care approach into your own care. So defining palliative care, this definition came from my friend and colleague, Steve Pantelot, who is the head of the Palliative Care Leadership Center at the University of California, San Francisco, that palliative care is about living as well as possible for as long as possible. And this definition may seem surprising to some people, but I would underline the word living, and that there is a difference between living and surviving. That living involves joy, living involves meaning, living involves choice and freedom. And that for most people, the goal is really to try to have as full a life, to be as fully alive for as long as they can. And then when that is no longer possible, people do not often want to merely linger, as some of my patients have put it. To be clear, palliative care is not the same as hospice. We'll talk about what hospice is. Hospice is palliative care for people at the end of life, but palliative care really can start a lot earlier than that. Palliative care is not euthanasia or death squads. It's not giving up on patients or doing nothing. And I think some of this comes from language that we use a bit unintentionally. When people go to a hospital, they'll sometimes be asked, do you want everything? And in our biomedical model, what everything means is being on machines, is getting dialysis, or doing a lot of things to keep somebody alive for as long as possible, to focus on survival. But sometimes we can do everything for other goals. We can do everything to get somebody home, to be with their family, to be comfortable, to have dignity. And we spend a lot of time in palliative care, sometimes more time in palliative care than outside of palliative care, really trying to support people and families in achieving the goals of their life, and also to have a comfortable death when that time comes. Palliative care is not only for people who are near death, and I'll present evidence that doing palliative care earlier may actually be better. It's not just for people living with cancer. There's historical reasons why palliative care has been associated with cancer, but over the last decade, palliative care has really expanded in a lot of areas, including neurology. And palliative care is not just for palliative care specialists. And this idea will become important later when we talk about how you can advocate to get palliative care for yourself. But a key part of the collaboration that we're doing now with the Parkinson's Foundation is to get neurologists to incorporate a palliative care approach into the care that they're providing. So talking about what palliative care is, it was really designed to address gaps in our care for people living with serious illness. And Parkinson's is a serious illness, cancer is a serious illness, Alzheimer's is a serious illness. And palliative care does this by focusing on enhancing quality of life. To give an example of that, quality of life includes both positive and negative aspects. And one of my patients who I saw yesterday, they, as part of quality of life, had their RV modified so that they can travel. They've been traveling for the last 6 months. They've been on highway 66 in New Mexico and Sedona, and they're going to Savannah, and are really making the most out of the time that they had. And some of that decision came from serious conversations that we had under this palliative care approach. We want to support patients to live as actively as possible. We recognize that family is part of the care package. And one of the things which I say a lot is that Parkinson's doesn't just affect one person. It affects a family, it sometimes affects a community. And so our care model needs to include care for everybody who's affected by that illness. Palliative care provides relief from pain and other distressing symptoms. And in Parkinson's, some of these things are symptoms that are sometimes invisible or fall between the cracks, pain being one, fatigue being another, constipation. It affirms life and regards dying as a normal process. It addresses psychosocial and spiritual issues. Things not just depression and anxiety, which are psychiatric, but truly psychosocial, feeling demoralized, feeling hopeless, feeling sad, angry. That all falls under this umbrella. And it's also applicable early in the course of an illness. And in fact, the time of diagnosis is a time where people really have a lot of what we would describe as palliative care needs. And these needs can continue throughout the illness course. One of the things that's sometimes confusing about palliative care is that we use the same term to refer to kind of four different things. So one is palliative care as an approach and a philosophy of care. And this is palliative care, I would say, as a person-centered model of care as opposed to a disease-centered model of care. So with palliative care, we really want to support people living with illness, and that is our primary focus, and it's complementary to disease-focused care, where the focus is really more on curing or treating symptoms of a disease. Palliative care is a skill set, and this is something that we're working on teaching physicians and nurses and chaplains, but it's also something that I truly believe patients and their families can learn and can bring to and can accentuate their care. It's a specialty, so there are people who do fellowships in palliative care, palliative medicine, and hospice, and there are times where people need a palliative medicine specialist in order to get the palliative care they need. And it's also a public health goal. That we want to, as a society, make sure that people living with serious illness are supported as people throughout the disease course, from the diagnosis all the way through end of life. Palliative care complements standard chronic care, so it's not an either-or proposition. So in chronic care, and if we think about Parkinson's disease, we're doing a lot of things right. And so we have deep brain stimulation and medications and physical therapy and all of the things that you know about and that you hear about. And palliative care really is designed to complement that. And so it's designed to take what we're doing well in terms of chronic care of your illness and disease, and to supplement it by focusing on what Cicely Saunders termed the total pain of serious illness, meaning not just the physical part, but also psychosocial, spiritual, and practical challenges that come along with the serious illness. We focus on overall well-being, so again, on living as fully as possible, as well as reducing suffering. We want to affirm and value life, while at the same time planning for inevitable decline of health and end of life. We focus on people living with illness as well as their families, and we almost always use a team approach because there are so many different facets of supporting a person living with a complex illness like Parkinson's. Kirk Hall, who is a friend of mine, somebody living with Parkinson's and an outstanding advocate, wrote a paper that's been very influential to me, where he talks about palliative care for Parkinson's as a three-legged stool. And that if we want to have optimal palliative care for people with Parkinson's, that we're going to have palliative care specialists who understand and know Parkinson's. We need community and disease support organizations like the Parkinson's Foundation, like local support groups who can provide some of the care that's necessary in the community. And then we need primary care providers and non-palliative specialists like neurologists who understand the palliative care approach and be able to get patients the care they need at the right time. And we're working on kind of strengthening all three of these legs of the stool. Hospice, just to be clear, is specialized palliative care for people with a terminal diagnosis. And hospice varies from country to country, but in the United States, hospice is palliative care for people with an expected life expectancy of 6 months. That being said, we don't have crystal balls, and people can live longer than that. My record holder was on hospice for 6 years. Sometimes people, when they get the care of hospice and they get out of the revolving door of going in and out of the hospital, actually do better and sometimes graduate from hospice because they're doing better than when they started. So I want to make sure that people understand that choosing hospice is not choosing to die. It's not necessarily mandatory that you die within 6 months. The goals of hospice really are to maximize comfort, to maximize time with family, and to avoid medical procedures in hospitals. That's really the primary goal. And I think with COVID, a lot of people have turned to hospice because visitor restrictions and other things about hospitals and also nursing homes have made these other traditional options much less attractive. Hospice includes medical support, it includes social and spiritual support. Most of the time, hospice, 90% of the time, hospice goes wherever you are, and that could be at home, it could be in a nursing home. It's actually uncommon that people go to hospice as a building. And hospice is covered by Medicare and it's covered by all insurances. So I know, particularly in the United States, people worry about the cost of healthcare, but fortunately, hospice is something that is covered for everybody. And the term neuropalliative care refers to palliative care that addresses the unique needs of people living with neurologic illness, such as Parkinson's, and we'll talk about that in a second. The recipe for neuropalliative care is that you need people who really have a deep understanding of neurologic conditions and treatment. And Parkinson's is very different than cancer, and so there's a large need for us to educate people in hospice and palliative care who are used to taking care of people with cancer to what are the needs of people with Parkinson's. At the flip side of that is that neurologists and others who work in the field of Parkinson's need to develop competence and learn the palliative care approach. We need supportive teams, systems, institutions, and policies. And then we need really outstanding communication if we're going to do neuropalliative care right. So the needs in Parkinson's disease are really vast. So this is a graphic of this concept of total pain. And so you can see that there are physical needs, there are psychological needs, there are social needs, there are spiritual needs, and we'll kind of go through these piece by piece. So palliative care needs, and I don't need to tell people in the audience this, but I put up this slide in part because I think doctors oftentimes need to hear this, is that these needs really begin with diagnosis. And this is a paper from 2006 that I call Dropping the Bomb, the experience of being diagnosed with Parkinson's disease. And so getting a diagnosis like Parkinson's, like cancer, like heart failure, is like having a bomb dropped on your world. And so we really need to recognize and anticipate that this can be a very intense period of time for somebody living with Parkinson's and their families. These needs rise and fall throughout the illness journey. And so you can see here around the time of diagnosis, there's a spike in needs. But over the course of the illness, there can be a loss of ability to drive, effect of people's work, need for assistance with dressing, times where the disease is accelerating, and all those times may be times where we need more of a palliative care approach, and we may even need to bring in palliative care specialists. And we have to include end-of-life care. For a long time, there's been a myth that people with Parkinson's don't die of Parkinson's, they die with it. And unfortunately, Parkinson's is the 14th leading cause of death in the United States. So people can die of Parkinson's. Not everyone with Parkinson's will die of their Parkinson's, but a lot of people with Parkinson's do die of Parkinson's. And I think if we don't acknowledge that, and if we don't recognize it, then we can't help prepare families for the end stage of their illness. And even for people who die with Parkinson's, here's a sobering statistic, is the world mortality rate. This is an older slide from 1996. But the world mortality rate remains steady at 100%. And I put up this slide a little bit facetiously, but in the United States, I think we sometimes act as if death is optional, that our healthcare system acts as if death is optional. But of course, that's not true. And we don't have a choice of if we die, and we actually have little choice of when, but we do have more power than we realize over where and how we die. And for most people, if they had a choice, they would die at home surrounded by family rather than in a hospital or in an ICU. And there are things that we can do within the palliative care approach to ensure that happens. And there are things that we could do within the palliative care approach to do our best to make the remainder of somebody's life, whether that's months or years, as meaningful and connected as possible, rather than something that's meaningless and that's very medicalized. There's a need for a roadmap with Parkinson's, and this is something that came out of interviews that we did with people living with Parkinson's, is that they felt like they were basically kind of in a dark cave, living one day at a time, never knowing exactly what's ahead. And even though I don't have a crystal ball, I can't tell exactly what's coming up for somebody, I can provide them with anticipatory guidance of what is the best case scenario, what's the worst case, what does the road ahead look like, what are the choices that need to be made, what are the things that should be done today? And all of these things with the roadmap can help people feel better prepared and less anxious for what's coming up with their illness. There can be difficulties with coordinating care. This was an image I got from Google Images, and I think it was meant to be reassuring, but I think, to me, it feels a bit overwhelming. And for people into health with serious illness, I can't tell you how many times I've been told, why can't my doctors talk to each other? And palliative care and the palliative care approach can be very helpful in helping patients and families better coordinate their care. People are, I think, familiar in this audience with what are called non-motor symptoms, but there are a number of medical and psychiatric symptoms that come up with Parkinson's. And we know from studies that about half the time these aren't met. And part of the reason for that is that they're invisible symptoms. Doctors may not see them, doctors may not ask about them, and people living with Parkinson's may not know who to bring them up with, or may have some embarrassment about bringing them up. And these include things like dementia, like depression, like pain, fatigue. And these are things that really fall very squarely within the palliative care approach. And in fact, in our studies and in our work, we recommend that people use a checklist, that doctors use a checklist, but even patients can bring in a checklist to make sure that these types of symptoms are addressed. This slide, Prozac is not always the answer. This is part of the reason actually I got into palliative care. This gentleman lying on the couch says, could we up the dosage? I still have feelings. And when I was taking care of people with Parkinson's and other illnesses, I ran into situations where I felt sad. And if I put myself into this other person's shoes, I felt sad, and it didn't feel to me like it was depression. And so there's a lot of reasons why people can be sad or upset or worried that aren't psychiatric and aren't pathological. So these can include difficult emotions such as grief, guilt, anger, frustration, social isolation, and loneliness can be a big issue, and I think has been heightened with COVID. Care partner and family support, and also worrying about one's family, feeling guilty for potentially being a burden to one's family. The effect on relationships, particularly in the core relationships with one's partner, there can be sometimes some distance, and it's hard to re-navigate roles. Cosmetic issues and social stigma. One patient that we interviewed, I love this term, talked about her Parkinson's as a flamboyant illness because her dyskinesias and tremor brought attention to herself, which she didn't appreciate. There are financial worries that people have that we don't often talk about in the medical scenario, and people worry about the future in other ways. There are spiritual and existential issues that come up, and these don't have to be religious, although sometimes they are, and people do have challenges to their faith and sometimes question why God is doing this to me. But with something like Parkinson's, where we don't have a cure, it can be demoralizing, that people can feel very hopeless. And how do we maintain hope and meaning and connection in the face of an illness like this? A lot of times people feel challenged in terms of redefining their identity and even their sense of personhood with this illness. And I think this is a big difference between Parkinson's and cancer, is that Parkinson's really affects the core of a person. It's not something that somebody has, it's something that somebody is in a way. And that can become pretty complex from a spiritual and a psychological perspective. It's also important to think about spiritual practices, meaning, joy, love, and connection as ways to increase coping and resilience. And lastly, some of people's fears for the future, fears of death, fear of decline, fear of dementia, are ultimately spiritual and existential issues, and really benefit from that kind of an approach. Advanced care planning is a term that just means to put things in writing, to have conversations to help your care team and to help your family know the care that you would want later in illness. And when we've done studies of this, people, when they know what it is, really want to do this soon after diagnosis. And I would strongly encourage people to not wait for the quote right time to do advanced care planning, because the right time usually means that the right time has passed. And we've done studies of this, and a lot of times these conversations happen after people are in the hospital and after they lose their ability to communicate. Something that I think is really a preventable tragedy is that currently people with Parkinson's are more likely to die in a hospital or nursing home than at home. And we know from our program, from the clinic I started at Colorado and the clinic at Rochester, is that with the palliative care approach, people are much more likely to die at home and to avoid hospitalizations in the last months of their life. And if we wait for the right time, as I said, these advanced care planning conversations often occur even in the intensive care unit, rather than in an environment where people living with Parkinson's actually have a chance to have a voice in their care. And last, but certainly not least, is care partner support. Care partners are at risk for their physical health. A lot of times people put their own health second when they're caring for somebody with an illness. Financial and social well-being, there can be loss of income, loneliness, and isolation from their caregiving activities, and certainly a lot of emotional and spiritual challenges, including burnout at one end of the spectrum. And so a key part of this palliative care approach is to make sure that we do the best job that we can to support care partners. And when care partners are doing well, patients also do better. So how does palliative care affect outcomes? This is a quote from Elena Summerall, who is a care partner advocate and has been a volunteer and a peer navigator at the University of Colorado. I see such a sense of relief on the faces of patients and care partners when they realize what is available to them through palliative care. They know they have a team to help them, they feel their symptoms are better addressed, and their concerns are heard. So we know from studies that we did that palliative care needs contribute to quality of life. So this was a study where we compared people with Parkinson's to people with terminal cancer, with metastatic cancer, and we found that palliative care needs were similar across both groups. And I think very importantly in this study, we showed that palliative care needs, things like spiritual well-being, things like overall symptom burden, things like care partner support, contributed to people's quality of life, even when we controlled for things like disease severity, depression, age, and other things that we traditionally think about determining quality of life. And so if our goal as a community is to improve quality of life, we absolutely need to address palliative care needs. Palliative care directly addresses what really matters to people living with serious illness. And from my conversations and the work that I do, these are the things that really matter to people living with serious illness, including Parkinson's. People want to spend time with their family. They want to make sure that their family is supported. People think a lot about and have very strong feelings about integrity and dignity, not just at end of life, but throughout their illness journey. People really want to have a roadmap for the future so that they can make better decisions today, but also so that they don't have to worry as much or have as much anxiety about what's to come. Symptom control, and in particular, things like pain, depression, and constipation have a huge impact on quality of life and oftentimes fall between the cracks in our current healthcare system. Joy may be something that you're surprised to see here. But we have a paper that should be coming out in the next few months where we asked people with advanced Parkinson's what were the most important determinants of their quality of life over the last 3 days. And over half of their responses were positive. They had to do with joy. They had to do with things that were positive in their life. And so I think it's really important that we work to support people, again, in living as fully as possible for as long as possible, including joy. And lastly is comfort and control near the end of life. People want to be comfortable, they want to be at home, and they don't want to be, essentially going through this conveyor belt of procedures near the end of their life, which is traumatic not only for the patient, but traumatic for the family who is watching things happen to their loved one. Palliative care is the future of medicine. So you heard a great talk about a lot of research that's happening, and there's no doubt, and don't get me wrong, that I'm also very excited about what's to come, and hopefully we do have a cure. And there's, we talk about gene therapy and small robots going into people and all of these things, but palliative care, I think, is more of the future of medicine than people realize. And if you look at trends over the last few decades, medicine is increasingly becoming patient and person-centered. That I think over the last century, we got very technologically focused and we got very enticed by the potential of technology, and that's important. But I think we paid a price in that, and that we sometimes lost sight of the patient and the person. And so the pendulum, I think, is swinging back more towards the middle. Palliative care is really essential to achieving the goals of medicine. And these have been laid out by a number of institutes, including the Hastings Institute. But when you look at the core goals of medicine, the relief of pain, the care and cure of those with illness, and the pursuit of a peaceful death, these are all strongly tied to palliative care. And over the last few decades, there's been talk about medicine's triple aim and then quadruple aim, which includes improving the patient experience, reducing cost, improving population health, and I would say increasing joy in practice, but reducing burnout for healthcare providers. And palliative care really supports all aspects of this quadruple aim. To improve care in advanced illness, we need to start at the time of diagnosis. We need to be proactive. So this cartoon here from Calvin and Hobbes says, Calvin, do you have an idea for your story yet? No, I'm waiting for inspiration. You can't just turn on creativity like a faucet. You have to be in the right mood. What mood is that? Last minute panic. And this is a cartoon that I think explains, in a sense, what it means to wait for the right time. That when we are putting off advanced care planning, when we are putting off conversations about end of life, we end up with a situation which is similar to our healthcare system, which is that a lot of things happen towards the end of life, a lot of things that people wouldn't necessarily want if they were able to think about them or choose them in advance. And when people do advanced care planning and complete advanced directives, it does reduce hospital deaths. So we do have evidence that these kinds of conversations absolutely do work, and they help us achieve our goals. And they are a gift not only to patients, but also to their families, who no longer have to feel like decision makers, but are instead able to simply be their family member or to be their voice as their illness progresses. This is a study that we published last year on outpatient palliative care for people with Parkinson's disease. And we showed in the study that for people with Parkinson's, that doing palliative care early, not just at end of life, improves a lot of important outcomes. So this is our current model of Parkinson's, or really almost any serious illness, where we have a neurologist who's taking care of motor symptoms and Parkinson's medications. About 50% of the time, they catch things like depression. We have primary care providers who are taking care of comorbid illnesses, non-Parkinson's medications. Care partners are kind of on their own, and the patient and family are really left to their own devices to figure out things like advanced directives, caregiver support, and spiritual needs. And so this is kind of our current state of affairs, that we do well with some things like motor control, fare with others like depression treatment, and not very well when it comes to end-of-life care and advanced care planning. And we hypothesized that if we were to add an extra layer of support here with a palliative care team, including a physician, nurse, social worker, and chaplain, that we would improve these outcomes like quality of life, caregiver support, non-motor symptoms, grief, and advanced care planning. And in fact, that's absolutely what we found. Patient quality of life improved 3 months into the study, and stayed improved at 6 months, which was our primary outcome. Care partner quality of life improved, and actually we found our biggest effect and in a growing effect at 12 months into the study, possibly because as the illness progresses, the support given by palliative care becomes increasingly beneficial to family members. People reported an improved sense of guidance, support, and clarity. They had better symptom control. One of the things that came up in our study that surprised us was that people not only had better non-motor symptom control, but better motor symptoms measured by the UPDRS. And that was not explained by changes in medication. What it was explained by actually was changes in mood. And we think that when people got palliative care, when they were able to focus on what was most important to them, that they were more active, more engaged, and better able to do the things that we know improve motor function. So how to get palliative care? So this is a quote from A.A. Milne, the author of Winnie the Pooh. "You are braver than you believe, stronger than you seem, and smarter than you think." And I put this quote here purposefully because I think a key concept here, maybe one of the most important ideas I think in this talk, is that you are a critical part of your healthcare team. And this is something that I've been pursuing increasingly in my research is how do we activate and empower people living with Parkinson's and their families to be an active part of their healthcare team, because no one is going to be more invested in your health than you are. I strongly believe, and there's some evidence to support this, that activated patients and families get better care. And so there's different ways that you can be a good patient. You can be, quote, compliant, listen, be quiet. But I think, activated patients who ask engaging questions, who work with their healthcare teams, actually will do better over the long run. And you do have opportunities to shape the care that you receive. So some of these opportunities to make your care more palliative is that you can create a checklist for your visits. And on that checklist, you can have invisible symptoms, you can have emotional needs, if you need care partner support, if you want to talk about advanced care planning. For a lot of providers, you can email them a list of questions in advance, or you could bring in the checklist and say, this is what I'd like to do today during our visit. You can ask questions that are important to you, and those can include some questions that may be scary. Am I going to die from this illness? What is the year ahead going to look like? I want to do a family trip or a family reunion. Should I do that sooner than later? Letting your team know what your values are. So the healthcare team, sometimes may make assumptions about what you would want, but it's important that you let people know what's most important to you. For some people, it's very important to not take a lot of medications, to avoid hospitals, to avoid surgery. For other people, it's important to be as aggressive as possible to get as much time as possible. So there's no right or wrong answers here, but it's important that your voice is heard in the care you receive. And it's really important to think about getting referrals, including to palliative care if you think you need that, or to get second opinions. And doctors, I think most doctors are mature enough to recognize that they don't have all the answers. And I think most doctors, aren't offended if you ask for a second opinion, and will, if you feel like you're not being seen or heard, or even if you're unsure of things, to get a second opinion is not the end of the world or a big deal. You can change your illness journey by including the positive in your approach. And this kind of comes through this general palliative care framework and what I would call positive medicine. But I think there's a tendency in our society, there's certainly a tendency in medicine to focus on what's broken, to be reliant on experts, to manage symptoms, what we would call a deficit-centered narrative for medicine and for illness. And we can switch that, and you can be a part of that switch to an asset narrative. Excuse me. So we can focus on what's working, focus on your strengths. And this is actually one of the joys of my practice, is I learn every day from the courage and wisdom and strength and grace of the people that I serve. A question that I love from a chaplain that I worked with is, how would you like to grow through this illness? And so there are a number of things that we can do to empower people, inspire people, and activate them. We now have sufficient evidence to establish palliative care as a new standard for Parkinson's. And this is the study that I mentioned earlier, is that the Parkinson's Foundation is working with me and others to make palliative care a new standard of care across the Centers of Excellence. And actually, Dr. Simon is part of our core team that's helping us to roll this out. We operationalize palliative care around 5 measurable and actionable pillars of areas that we want to improve. So we want to do advanced care planning conversations annually, and this is actually a quality metric advised by the American Academy of Neurology. We want to be systematic about assessing and managing non-motor symptoms so they don't fall between the cracks. We want to make sure that we recognize and support people's emotional and spiritual concerns, that we routinely assess and support care partners, and that we get people to specialist palliative care and hospice when they need it. For people who are interested about this, who are passionate about this, I would encourage you to become an activist. The Parkinson's Foundation has their Parkinson's Advocates in Research, or PAIR program, and I've worked with a number of PAIR graduates in this work. In fact, the paper below was written entirely by PAIR graduates. You can be active in your community with community projects and support groups, and a number of support groups are incorporating palliative care approaches and palliative care information in the work that they do. And you can also be a voice to change policy on a larger level. One of the things that is frustrating to me, and I think needs to be changed, is that hospice laws were written for people with cancer, not for people with Parkinson's. And an example of that is that people with Parkinson's often have to choose between physical therapy and hospice, even though physical therapy can be helpful right through the end of life. Your healthcare providers don't have to reinvent the wheel. There are a number of people who have done this work, and whether you're in the Parkinson's Foundation or outside of it, I'm always happy to talk to providers and to provide education. And there's an increasing number of resources for neurologists to learn about palliative care. There's still much work to be done, and if you're interested in it, I would encourage you to check out the International Neuropalliative Care Society. We have patients and care partners on our board. We look at patients and care partners as peers and colleagues and experts, and would love to have you become part of our society. Our mission and vision is to raise standards of care for all people affected by neurologic illness, and our vision is a world where high-quality, person-centered care is the rule rather than the exception. So the take-home points is that the goal of palliative care is to live as well as possible for as long as possible, that people living with Parkinson's have palliative care needs, and that these needs can be improved with palliative care approaches. People with Parkinson's and their families are critical members of the healthcare team, and people with Parkinson's can advocate for palliative and supportive approaches in their care. So I will turn things back over to David and answer questions.